Welcome to the deep dive. Today we are getting into what I think is easily one of the most frustrating, highly debated topics when you're sitting in a multidisciplinary team meeting.
Oh, absolutely.
Yeah, I mean, we're talking about breast pathology, but specifically the complex, really high-stakes world of papillary lesions.
Right, the lesions that give everyone a headache.
Exactly. I mean, we're applying the Royal College of Pathologists data sets, the FRCPath guidelines, and the WHO classification of breast tumors. But even with those Bibles open in front of us, these specific lesions routinely challenge our basic diagnostic paradigms.
They really do because, you can have a lesion that completely lacks a myoepithelial cell layer, which in literally any other organ or context, we would instantly classify as invasive carcinoma.
Right, without hesitation.
Exactly. Yet for these specific breast lesions, the WHO instructs us to stage it as PTIS, as an in situ disease.
Which is wild.
It is. The morphological rules and the expected biological behaviors just seem to constantly contradict one another in this very specific territory. And that contradiction is precisely why papillary lesions remain this massive hurdle in the FRCPath examinations and, frankly, in daily consultant practice.
Because it's not just a single disease entity, right?
No, not at all. We are dealing with an architectural pattern. The papillary architecture, those arborizing fibrovascular cores lined by epithelium, it's merely a structural framework.
A scaffolding.
Exactly, a scaffolding. And that scaffolding can host an entire spectrum of disease. I mean, everything from a completely benign intraductal papilloma driven by a localized hyperplastic response all the way up to a highly aggressive solid papillary carcinoma.
Right, and the guidelines are great. They're comprehensive. But applying them requires understanding the actual biology behind the patterns rather than just treating the WHO book like a rigid checklist.
You can't just check boxes. It will lead you astray.
Which brings us to our actual mission for this deep dive. For those of you listening, whether you're an advanced resident prepping for your final board exams or you're a consultant managing a really complex breast list right now, we are going to systematically dismantle the diagnostic approach to these lesions.
We want to build a bulletproof framework for you.
Exactly. We aren't just reading textbook definitions today. We are hunting down the diagnostic traps, the IHC pitfalls, the staging rules that make no intuitive sense but have very real consequences for your patients.
And to do that effectively, we have to start with the absolute foundational principle of breast pathology. And this becomes particularly critical when you're looking at an arborescent papillary structure.
The golden rule.
The golden rule. Morphology dictates the immunohistochemistry.
Always.
Always. The stains are subservient to the architectural and cytological evaluation of the H and E slide.
I mean, it's like looking at a compass before you've even opened your eyes to look at the landscape around you.
That is a perfect analogy. The moment a pathologist encounters a complex papillary lesion and just reflexively orders a huge panel of high molecular weight cytokeratins and myoepithelial markers before they've even formed a morphological differential diagnosis, they're completely setting themselves up for a diagnostic error.
Yeah, I see this all the time in the reporting room. There's this over-reliance on the objective color change of a stain to solve a structural problem.
Right. People want the brown stain to just hand them the answer.
Exactly. But if you haven't really drilled down and assessed whether the underlying architecture is an intact arborizing fibrovascular network, or if it's, say, been replaced by a rigid cribriform proliferation, the stains are just going to give you conflicting noise.
Because you don't know what you're staining.
Right. You might see patchy myoepithelial staining and instantly jump to, oh, this is invasion. When in reality, it's just a heavily sclerosed benign papilloma where the antigen expression has been downregulated by, like, ischemia and fibrosis.
Precisely. The H&E is the ground truth. You start there. And once you've evaluated the architecture, the diagnostic algorithm for navigating these lesions is heavily dependent on a sequential, logical evaluation of the myoepithelial cell layer, the MECs.
Right, and this is the core decision tree detailed in the WHO classification.
Exactly. The very first node in that decision tree, the first question you have to answer, is evaluating the presence or absence of MECs, specifically on the fibrovascular fronds themselves.
Right, so we're looking at the internal scaffolding of the lesion first.
Yes, internals first.
So if the MECs are present, if they're sandwiched nicely between the endothelial cells of the capillary cores and that overlying luminal epithelial layer, then we are looking at an architecturally intact papilloma.
Yes.
Because the presence of that internal MEC layer confirms that the fundamental structure of the ductal unit is preserved, even if it's totally proliferating and busy.
Exactly right. If MECs are present on the fronds, the lesion fundamentally falls into the benign papilloma category structurally. Your diagnostic task then completely shifts.
Right, you move to the epithelium.
Right, you shift entirely to evaluating the overlying epithelial compartment to determine if there's a secondary neoplastic process like atypical ductal hyperplasia or DCIS arising within that otherwise intact framework.
Okay, so that's question one. But if we go back to the decision tree, the real divergence happens when those internal MECs are absent.
Yes, when the internal scaffolding is stripped.
So if the fronds are devoid of MECs, the algorithm forces us to look outward, right, to the periphery of the involved duct space.
Out to the walls.
Right. And this is where we start differentiating between papillary DCIS and the encapsulated or solid variants. So in papillary DCIS, the neoplastic proliferation has completely replaced the internal epithelial and myoepithelial layers of the fronds.
Leaving only these bare collagenized vascular cores.
Yeah. Yet the peripheral MEC layer, the actual boundary of the expanded duct, remains entirely intact. It's like the duct wall acts like a castle wall. The invaders have taken the courtyard, they've destroyed the internal structures, but the outer defenses are totally holding.
That is exactly the biological reality. And that is the defining immunohistochemical signature of papillary DCIS. Absent internal MECs, retained peripheral MECs.
Because the clone is just in situ.
Right. The neoplastic clone lacks the biological machinery to maintain the complex biphasic cellular relationship on the internal fronds, but it hasn't yet acquired the proteolytic enzymes like the matrix metalloproteinases necessary to degrade the basement membrane and breach that final outer peripheral defense line.
It's aggressive but contained.
The disease is extensive within the ductal system, sure, but it remains strictly in situ.
Which logically leads us to the next nightmare scenario.
A third node.
Right. If the MECs are absent on the internal fronds and we then pan out to examine the periphery and we find that the peripheral MEC layer is also completely absent.
Right, the boundary has failed.
Structurally, yes.
Yeah.
And under standard pathological principles, this screams invasive disease. The walls are gone. However, the WHO algorithm requires us to stop and ask a third morphological question before making that call.
And this is where people trip up.
Yeah. The question is there a thick, continuous fibrous capsule surrounding the proliferation?
And that question introduces the entity of encapsulated papillary carcinoma, or EPC. If there are no MECs anywhere, internally or peripherally, but the entire lesion is perfectly circumscribed by a thick, fibrous capsule, it is classified as EPC.
And if there's no capsule?
Yeah, there's no capsule, and you just have a solid proliferation of cells lacking MECs, then we are in the territory of solid papillary carcinoma, SPC, or potentially true invasive papillary carcinoma.
Okay, wait. Before we get lost in the staging paradoxes of EPC and SPC, because those are confusing enough, we need to address that true invasive papillary carcinoma category.
Oh, absolutely.
Because the WHO explicitly warns that true invasive papillary carcinoma of the breast is an exceptionally rare entity, like unicorn rare.
It is exceedingly rare.
Yet, if you look at routine audits, or if you're taking outside consultation cases, we frequently see this diagnosis thrown around, invasive papillary carcinoma. So if it's so overdiagnosed, what are pathologists actually looking at when they call it that?
Usually, it's a massive morphological misinterpretation. When pathologists diagnose a true invasive papillary carcinoma, they're almost always looking at an invasive component of a completely different primary lesion.
Like an EPC that's burst.
Exactly. Most commonly, they're observing an encapsulated papillary carcinoma or a solid papillary carcinoma that has developed an area of frank invasion beyond its borders. The primary biology is EPC or SPC, and that invasive component should be measured and staged strictly as such.
Ah, so the papillary part isn't the invasion, it's the primary tumor architecture.
Right. A de novo invasive carcinoma that exclusively forms true, arborizing papillary structures while infiltrating through desmoplastic breast stroma is practically unheard of.
But there is a much, much more dangerous diagnostic trap here than just misclassifying the specific type of breast primary.
The metastatic mimic.
Yes. The breast is a rich vascular bed, and tumors from other organs that naturally grow in papillary architectures love to metastasize here and maintain that exact same morphology.
It's a huge pitfall. Ovarian serous carcinomas, lung adenocarcinomas, papillary thyroid carcinomas, all of these can present as a solitary breast mass with striking papillary morphology on a core biopsy.
And if you're just looking at it thinking, well, it's in the breast, so it's a breast tumor, you're in trouble.
If a pathologist encounters a papillary tumor infiltrating the breast stroma and fails to even consider a metastatic origin, the clinical consequences are, frankly, catastrophic.
Because the treatments are totally different.
Entirely different. The systemic therapy regimens for a primary invasive breast carcinoma versus a metastatic ovarian serous carcinoma have almost zero overlap. You would be giving the patient the completely wrong chemotherapy.
Which underscores why seeing that morphological pattern has to immediately trigger a site of origin IHC panel. I mean, if I see an invasive papillary pattern, especially if the cells exhibit high-grade serous features, extreme nuclear pleomorphism, prominent macronucleoli,
You should be reaching for the adnexal markers.
immediately. I'm adding WT1, PX8, and P53 to the panel right then and there to exclude an adnexal origin. Or if the cells have like a hobnail appearance or clear cytoplasm, TTF1 and apsin are mandatory to rule out a primary lung adeno.
You absolutely cannot assume a breast origin simply based on the anatomical location of the needle.
Okay, so assuming we have done that rigor, we've excluded a MET, we are confident it's a primary breast lesion, and we are working through our intrinsic decision tree, we hit the next major operational hurdle.
The stain's lying to us.
Exactly. The entire algorithm we just built relies entirely on our ability to accurately detect the presence or absence of myoepithelial cells. And this is exactly where the stains frequently, and I mean frequently, deceive the unwary pathologist.
They're notoriously tricky in papillary lesions.
Let's analyze the false positives first, seeing MECs that literally aren't there. Historically, we relied on smooth muscle actin, SMA, and calponin as our standard markers for MECs.
And unfortunately, many laboratories still run them as their routine frontline panel.
Right. And the problem is that those markers are detecting contractile proteins in the cytoplasm. But in the microenvironment of a breast carcinoma, myoepithelial cells are absolutely not the only cells utilizing contractile proteins.
Not by a long shot. The tumor microenvironment is incredibly reactive. As a neoplasm grows and infiltrates, it induces desmoplasia. That's a massive proliferation of reactive stromal fibroblasts that differentiate into myofibroblasts.
And what do myofibroblasts express?
Smooth muscle actin and calponin. Strongly. Furthermore, the tumor is actively stimulating angiogenesis, right? It's bringing in new capillaries to feed those fibrovascular cores.
And those capillaries need support.
Exactly. The parasites that wrap around and physically support those newly formed capillaries also strongly express SMA and calponin.
So if you're evaluating a truly invasive carcinoma that has provoked a really robust desmoplastic reaction, and you throw calponin on it to see if a peripheral MEC layer is retained,
the calponin is going to intensely stain the reactive myofibroblasts wrapping right around the invasive tumor nests.
and under low power, it creates this beautiful, continuous brown ring that perfectly, flawlessly mimics an intact myoepithelial layer.
It looks exactly like a duct wall. And you look at that false positive stain, you believe it, and you erroneously conclude the tumor is confined.
You literally understage an invasive carcinoma as in situ.
It is one of the most dangerous false positives in all of breast pathology. And this is precisely why the WHO and the FRCPath datasets strongly advocate moving away from cytoplasmic contractile markers and utilizing nuclear markers instead.
Specifically P40.
So specifically P40.
So for the listeners, the distinction between P40 and the older standard P63 is critical here, because both are targeting the TP53 gene family. Right?
Yes, but they do it differently.
Right. P40 specifically detects the delta MP63 isoform, which is heavily concentrated in myoepithelial nuclei. Because it's a nuclear transcription factor, it completely ignores the cytoplasmic proteins in the stromal myofibroblasts and those vascular parasites.
It's brilliant. It effectively filters out all that reactive stromal noise that calponin and SMA light up like a Christmas tree.
So if you run calponin and P40 concurrently on that invasive nest surrounded by desmoplasia, what happens?
The calponin will be screaming positive in the stroma, but the P40 will be completely starkly negative. The discordance immediately unmasks the false positive.
It's such a clean way to solve the problem.
Yeah.
But wait, I mentioned P63 earlier, and we really need to discuss why P40 is superior to P63, specifically in the context of these papillary lesions. Because I know a lot of people still think P63 is the gold standard.
P63 is an excellent myoepithelial marker in normal, totally benign breast tissue. But in neoplastic papillary lesions, we frequently encounter a very specific trap. aberrant expression.
Meaning the tumor cells themselves start expressing it.
Yes, the neoplastic luminal epithelial cells themselves can upregulate p63, showing strong, diffuse nuclear positivity.
Wow.
So if you rely solely on p63, you are going to see those positive nuclei lining the fronds and falsely conclude that a benign MEC layer is present.
You'd look at a papillary DCIS and downgrade it to a simple papilloma.
Exactly. The mechanism behind that aberrant expression is linked to the complex molecular alterations in the neoplastic clone itself. The transactivating TAP63 isoform is sometimes overexpressed by these luminal cells.
But P40 doesn't pick that up.
Right. P40, by strictly targeting the delta NP63 isoform, completely bypasses this specific aberrant expression profile. The luminal neoplastic cells almost never express the delta NP63 isoform.
So the rule of thumb is, if you see columnar, atypical-looking cells lining a frond that are strongly positive for P63, but entirely negative for P40.
And negative for a cytoplasmic marker, like smooth muscle myosin heavy chain 2.
Right. Then you have confirmed aberrant luminal expression. It's a false positive P63. It's not a retained MEC layer.
Exactly. You stick to P40.
Okay, so that covers the false positive. So you just mentioned smooth muscle myosin heavy chain, SMMHC. And while we use P40 to avoid false positives, SMMHC introduces the opposite risk, right, the false negatives, missing the MECs that are actually there.
Yes. SMMHC is highly specific to myoepithelial cells, so it doesn't suffer from the myofibroblast cross-reactivity that SMA does. However, its expression is notoriously fragile in the face of tissue remodeling.
It just disappears.
It does. Think about a sclerosing papilloma. The dense collagenous stroma induces ischemia and intense physical compression.
The cells are getting crushed.
Right. The myoepithelial cells often survive this hostile environment, but they undergo phenotypic modulation. They literally downregulate their cytoplasmic contractile apparatus just to survive, leading to a complete loss of SMMHC expression on the stain.
And the same thing happens with distension, doesn't it?
Yes. In ducts that are massively distended by high-grade DCIS, the sheer physical pressure and the altered paracrine signaling from the neoplastic cells cause the peripheral MECs to just turn off SMMHC production.
This creates a terrifying scenario. The MECs are physically present. They are still holding the line, maintaining the architectural boundary, but they are immunophenotypically silent for SMMHC.
They're invisible to that specific antibody.
So if a pathologist relies exclusively on SMMHC to evaluate a really sclerosed area of a papilloma, the stain will be completely blank.
And they'll conclude the MEC layer is lost.
And erroneously diagnose an invasive carcinoma, a false positive for cancer based on a false negative stain.
Which is exactly why the FRCPath guidelines dictate that myoepithelial evaluation must always involve a panel. You cannot rely on a single antigen.
It's too risky.
Far too risky. The recommended approach is to anchor your panel with the robust nuclear marker P40 because it's highly resistant to downregulation in sclerosing environments, and then supplement it with SMMHC or a basal cytokeratin like CK56 or CK14. They essentially compensate for each other's specific vulnerabilities.
In modern laboratories, we really streamline this by utilizing multiplex immunohistochemistry, specifically the ADH5 cocktail.
The ADH5 cocktail is an absolute game changer.
It really is, especially for evaluating the really complex heterogeneous populations within a papillary lesion. For the listeners who might not use it daily, the ADH5 cocktail is a ready-made tool that applies 5 different antibodies simultaneously on a single tissue section utilizing dual chromogens.
It's incredibly efficient.
Yeah, it combines luminal cytokeratins, so CK7 and CK18, which are usually flagged with a brown DAB chromogen alongside basal and myoepithelial markers like CK5, CK14, and P63, which are flagged with a red or magenta chromogen.
And the diagnostic utility of seeing all of that on one flight cannot be overstated, particularly when we transition to the next critical phase of the algorithm, which is evaluating the epithelial proliferation itself.
Right, because once we've established via the presence of MECs on the fronds that we're dealing with a structurally intact benign papilloma scaffolding, we still have to interrogate the cell proliferating on top of those fronds.
We have to differentiate usual ductal hyperplasia, UDH, from atypical ductal hyperplasia, ADH, and low-grade DCIS.
And the ADH5 cocktail beautifully visualizes the fundamental biological difference between those entities, which is polyclonality versus monoclonality.
Exactly. UDH is a hyperplastic polyclonal process. It arises from the expansion of various progenitor cells, resulting in this really mixed, heterogeneous population of luminal cells and basal-like intermediate cells.
So when you apply the ADH5 cocktail to UDH, you see a chaotic mosaic pattern.
A beautiful mosaic.
Yeah, you have patches of cells expressing the brown luminal markers intimately intermingled with irregular clusters of cells expressing the red basal markers like CK5 and CK14.
And that mosaicism is the immunophenotypic hallmark of benign hyperplasia. Architecturally, on the H&E, this polyclonality manifests as disordered growth.
The streaming effect.
Yes. The cells in UDH stream over one another, creating irregular slit-like fenestrations rather than geometric spaces. Their nuclei are totally variable in shape and orientation.
But contrast that with the biological etiology of ADH and DCIS, because these are neoplastic monoclonal proliferations.
Right. They originate from a single, rogue, luminal epithelial cell that has acquired a specific set of genetic alterations, often things like the loss of chromosome 16q.
And because they are clones of a single luminal cell, their immunophenotype is entirely uniform. They completely lack the expression of high molecular weight cytokeratins.
Totally negative.
So on an ADH5 cocktail stain, a focus of ADH or DCIS is going to be starkly monotonous. It will be diffusely, homogeneously brown, expressing only CK7 and CK18, with an absolute absence of the red CK5 or CK14 staining within that neoplastic population.
Furthermore, if you apply an estrogen receptor stain, ER, that clonality is equally apparent.
Oh, absolutely.
UDH displays heterogeneous patchy ER positivity. Some cells are intensely positive, others are completely negative, which just reflects their diverse polyclonal origins. A low-grade chronal neoplastic proliferation, however, will exhibit strong, diffuse, uniform ER positivity in virtually 100% of the cells.
The biological uniformity dictates the visual uniformity.
Yes, but as with everything in breast pathology, there is a significant pitfall here.
There always is.
We have to talk about the pitfall associated with utilizing CK56 or CK14 as a discriminator for clonality, specifically regarding apocrine metaplasia.
This is such a critical warning. Apocrine metaplasia is a super common reactive change within papillomas. It's characterized by those distinct cells with abundant granular eosinophilic cytoplasm and really prominent nucleoli.
They're very easy to spot morphologically.
Right. But biologically, apocrine cells are epithelial. Their specialized differentiation means they naturally downregulate basal cytokratins.
Exactly. An area of classic, completely benign apocrine metaplasia will be completely negative for CK56 and CK14.
So if a pathologist is overly reliant on the IHC paradigm that, negative high molecular weight cytokeratins equals clonal neoplasia, they're going to look at a completely benign apocrine cyst, see that it is CK56 negative, and tragically upgrade it to DCIS.
I've seen it happen. It's an enormous error. Upgrading a lesion just because a benign apocrine area is CK56 negative is a failure to prioritize morphology.
Because the H&E architecture of apocrine metaplasia is so distinct.
It is, and if you really need immunohistochemical confirmation, apocrine cells will be strongly positive for the androgen receptor and negative for the estrogen receptor.
Which is the exact opposite of the typical low-grade DCIS profile.
Exactly. Morphology must drive the interpretation of the stain.
Okay, so assuming we have successfully navigated all of these pitfalls, we've proven the H&E, we didn't fall for the false positives or false negatives, and we have definitively identified a clonal neoplastic proliferation within a papilloma.
It's monotonous. It forms rigid geometric cribriform spaces or micropapillae.
Right. It's completely negative for CK56 and diffusely positive for ER. So we have proven it is neoplastic. The next challenge, which is strictly dictated by the FRCPath datasets, is classifying that neoplastic clone as either ADH or DCIS.
And this brings us to the famous 3-millimeter rule.
Right. For low-grade neoplastic proliferations within a papilloma, the threshold between ADH and DCIS is purely quantitative.
It's just a measurement.
Right. If the maximum contiguous dimension of the low-grade clonal population is less than 3 millimeters, it is categorized as atypical ductal hyperplasia, ADH.
And if it reaches or exceeds 3 millimeters, it crosses the diagnostic boundary into low-grade ductal carcinoma in situ, DCIS.
So the obvious practical question is, why 3 millimeters? I mean, how exactly do we measure this grade to know if the rule even applies?
Well, the 3-millimeter threshold is essentially a surrogate marker for biological volume and chronological development. It provides pathologists with a reproducible, objective metric to standardize diagnoses across different centers, so we aren't just guessing.
Makes sense.
However, the absolute prerequisite for applying the 3-millimeter rule is establishing that the proliferation is, in fact, low grade.
Right.
The entire paradigm completely collapses if the nuclear grading is evaluated incorrectly.
Because the nuclear grading of breast neoplasia is a highly specific morphological skill.
Mm.
We do not evaluate the architectural pattern for grade, right? We're evaluating the intrinsic characteristics of the individual nucleus.
And to do that, you need a yardstick.
Right. The most reliable internal reference standard we have on any H&E slide is the mature red blood cell, which is consistently around 7 microns in diameter. We use the red blood cell as a microscopic yardstick to evaluate nuclear enlargement.
It's the best internal control you have. Let's detail the specific criteria for the listeners. A low-grade nuclear proliferation is characterized by nuclei that are small, generally ranging from 1 to 1.5 times the diameter of a red blood cell.
So just slightly larger than an RBC.
Right, but size is only one parameter. Monomorphism is equally critical. In low-grade lesions, the nuclei are virtually identical to one another in size and contour.
They look like clones.
They are clones. The nuclear membranes are smooth and regular. The chromatin distribution is finely stippled and even. There's absolutely no aggressive clumping. Nucleoli are either inconspicuous or completely absent, and mitotic figures are exceedingly rare.
It's a proliferation that looks remarkably uniform and, honestly, quiescent, despite its neoplastic nature.
Yes, it looks quiet.
And it is this specific indolent biological profile that allows us to apply the 3 millimeter leniency rule in the first place. But when we transition to intermediate grade atypia, the morphological features begin to reflect increasing genomic instability.
The machinery is breaking down.
Right. The nuclei enlarge, reaching 1.5 to 2 times the diameter of the red blood cell. And we begin to see moderate pleomorphism.
The cells are no longer exact clones visually. There is noticeable variation in size and shape from cell to cell.
And in intermediate grade nuclei, the chromatin becomes coarser, right? Reflecting the disorganized transcriptional activity of an increasingly aneuploid genome.
Exactly. Small to moderately sized nucleoli become visible, indicating heightened ribosome synthesis to fuel cell growth. You will begin to identify occasional mitotic figures. It's a transitional morphology. It represents a tumor clone that is actively acquiring more aggressive biological capabilities.
Which leads us to high-grade nuclear atypia, which represents the culmination of that genomic instability. The nuclei are markedly enlarged, generally exceeding twice the size of a red blood cell.
And the extreme pleomorphism means you will see a wild variation in nuclear sizes within the very same high-power field.
The nuclear contours are totally highly irregular, folded, and jagged.
The chromatin in high-grade cells is coarsely clumped and condensed, frequently marginated right against the nuclear membrane. Prominent, often multiple, macronucleoli are present. Mitotic activity is brisk.
You'll frequently observe atypical mitotic figures, right? Like multipolar spindles and lagging chromosomes, which are just visual evidence of a completely chaotic cell cycle.
Exactly. Furthermore, the rapid, unchecked proliferation often outstrips the local vascular supply, resulting in areas of comedonecrosis, where the very center of the involved duct contains necrotic cellular debris.
So accurately distinguishing between these 3 nuclear grades is the most critical step, because of the major, crucial exception built into the FRCPath and WHO guidelines.
The exception that changes everything.
Right. The 3 millimeter rule is strictly restricted to low-grade lesions. If the neoplastic proliferation exhibits intermediate or high-grade nuclear atypia, the 3 millimeter size threshold is completely abandoned.
Thrown out the window. This is a paramount teaching point. If you identify an intermediate or high-grade clonal proliferation within a papilloma, any quantitative amount of that proliferation constitutes a diagnosis of DCIS.
Even if it's tiny.
Even if the focus measures only 1 millimeter, the aggressive biological potential dictated by the high-grade nuclei completely overrides the arbitrary spatial threshold.
Because the high-grade clone possesses the mutational burden necessary to progress rapidly and metastasize.
Right. Requiring a pathologist or a surgeon to sit around and wait until it achieves a 3 millimeter volume before initiating definitive oncological management would be a massive, unacceptable clinical risk.
And this biological override directly dictates our clinical management strategies, particularly regarding the use of vacuum-assisted excision, or VAE.
Oh, VAE, the bane of our existence sometimes.
Seriously. So VAE devices utilize a large bore needle and a vacuum mechanism to excise really significant volumes of tissue, often retrieving 4 grams or more. Now, for a benign, completely unremarkable intraductal papilloma without any evidence of atypia, a therapeutic VAE is increasingly considered acceptable and potentially curative.
Because it physically removes the offending symptomatic lesion, it's great for that.
Right. However, the moment atypia is introduced into the diagnostic equation, even if it is simply a 1 millimeter focus of low-grade ADH,
VAE ceases to be an acceptable definitive treatment, full stop. The presence of any atypia mandates a formal, surgical-wide local excision.
and the reasoning is purely mechanical, right?
Yeah.
It's tied directly back to our need to measure the lesion. A VAE does not deliver an intact surgical specimen.
Not at all.
The vacuum mechanism physically fragments and shears the tissue as it pulls it through the cannula. So we receive multiple irregular cores and tissue fragments just floating in the cassette.
A jigsaw puzzle.
Exactly. If we identify a low-grade clonal proliferation within these fragmented pieces, it is physically impossible to accurately reconstruct the three-dimensional architecture to determine if the maximum continuous dimension exceeds 3 millimeters.
You cannot reliably apply the 3 millimeter rule to a jigsaw puzzle that's missing half its pieces. Furthermore, you cannot adequately assess the peripheral margins to ensure the entire atypical clone has been removed.
Right. Therefore, identifying atypia on a core or a VAE necessitates an intact surgical excision where the pathologist can ink the margins, section the tissue serially, and provide definitive staging and margin status for the multidisciplinary team.
We have to have intact borders to do our job.
Which is a perfect segue, because this concept of accurately defining boundaries brings us perfectly to the staging paradoxes of papillary lesions.
The paradoxes, yes.
We apply meticulous rules to measure 3 millimeter boundaries for ADH. Yet when we evaluate encapsulated papillary carcinoma and solid papillary carcinoma, the established rules of tumor boundaries and invasion seem to be entirely rewritten.
They defy basic logic at first glance.
Let's dissect the biology of EPC first. Okay, let's unpack this.
Yeah.
Encapsulated papillary carcinoma has no MECs at all. Doesn't that scream invasion? Why is it staged as PTS, in situ?
As we established in our initial algorithm, EPC is defined morphologically by a complex papillary architecture that entirely lacks myoepithelial cells, both on the internal fibrovascular fronds and at the thick fibrous capsule surrounding the lesion.
Right, and in standard breast pathology, the complete absence of a myoepithelial layer is the definitive hallmark of invasive carcinoma. It signifies that the neoplastic clone has totally destroyed its native containment.
Structurally, you are completely correct. Structurally, EPC is an invasive tumor. It has breached the ductal boundary. Yet, the WHO classification explicitly mandates that an unruptured EPC, confined within its fibrous capsule, must be staged as PT, carcinoma in situ.
Which creates immense cognitive dissonance for trainees. I remember learning this and just being like, wait, what? Why are we staging an entity with no myoepithelial boundary as an in situ disease?
Because we stage it based on biological outcome, not morphological logic, the WHO staging system is ultimately designed to predict prognosis and guide therapy, not merely to describe microscopic structures for an anatomy textbook.
It's functional.
Exactly. Extensive long-term follow-up data has consistently demonstrated that patients with EPC confined by a fibrous capsule experience survival rates that are statistically indistinguishable from standard, fully contained DCIS.
The biological mechanism explaining this is still a subject of ongoing debate, isn't it?
Oh, massive debate. Some hypothesize that the thick fibrous capsule is not actually a desmoplastic reaction to invasion, but rather a massively expanded, hyalinized native duct wall. And the theory is that the peripheral myoepithelial cells haven't actually been destroyed, but merely attenuated beyond the limits of our immunohistochemical detection.
They're just stretched too thin to stain.
Right. Others argue, no, it is a low-grade invasive tumor, but it triggers such an overwhelming fibrotic containment response from the host stroma that it effectively traps the tumor before it can access the lymphovascular networks.
Regardless of the specific etiology of the capsule, its clinical efficacy as a barrier is just undeniable.
It works. Lymph node metastases from a pure, intact EPC are extraordinarily rare, and distant metastases are virtually non-existent.
So staging this entity as an invasive carcinoma would subject these patients to really aggressive systemic chemotherapies and axillary clearances that offer zero survival benefit.
While causing massive iatrogenic morbidity, staging it as PTES fundamentally protects the patient from overtreatment.
However, that protective staging applies exclusively when the fibrous capsule remains intact.
Yes, the capsule is everything.
If the neoplastic cells permeate beyond the outer border of that fibrous capsule and exhibit irregular, jagged, infiltrative growth into the adjacent breast parenchyma or adipose tissue, the biological barrier has failed.
This is defined as frank invasion.
And when frank invasion occurs, the PTS designation is revoked immediately.
Instantly. The lesion is then staged based entirely on the maximum dimension of the frank invasive component outside the capsule, typically as PT1 or PT2, totally ignoring the volume of the encapsulated portion.
But there is a secondary critical caveat within the WHO guidelines regarding EPC that bypasses the architectural evaluation entirely, right?
The biological override.
This is a rarely known WHO rule, but it's vital.
It is. The WHO states that if an EPC, even one with a perfectly smooth, completely unbreached fibrous capsule, exhibits aggressive biological markers, it must be staged and managed as an invasive breast carcinoma.
Even if the capsule is totally perfect.
Even if it's perfect. Specifically, if the neoplastic cells demonstrate high nuclear grade, brisk mitotic activity, or if the tumor possesses a triple negative or HER2 amplified molecular phenotype, the PT staging is just no longer applicable.
Because biology overrides morphology.
Exactly. This rule acknowledges that highly aggressive molecular phenotypes inherently possess the capacity for early micrometastasis and rapid progression, irrespective of the current morphological appearance of the capsule.
The biological potential of a HER2-driven tumor clone cannot be trusted to remain confined by a local fibrotic reaction.
No, it will escape. The staging must reflect the systemic threat, overriding the localized morphological snapshot.
That perfectly illustrates the tension between structure and biology. Now let's examine solid papillary carcinoma, SPC, which presents a different paradigm entirely.
SPC is fascinating.
It is. SPC is characterized by a solid, cohesive proliferation of monotonous cells, often displaying neuroendocrine differentiation, growing in these circumscribed expansile nodules.
And the fibrovascular cores are present, but they're incredibly fine and delicate, often totally compressed by the sheer cellular density.
Right, and crucially, unlike EPC, the myoepithelial status in SPC is completely variable and, frankly, non-diagnostic. You may find an intact peripheral MEC layer, a patchy MEC layer, or a completely absent MEC layer.
The critical teaching point from the FRCPath dataset here is that in solid papillary carcinoma, the absence of myoepithelial cells does not equate to invasion.
So how do we spot invasion in SPC if the stains don't tell us?
If we cannot rely on the MEC stains to define invasion, we are forced to rely entirely on the low-power architectural contours of the tumor nodules.
The shape of the border.
Yes. And in situ, indolent SPC is defined by smooth, rounded, sharply demarcated borders. The nodules push against the surrounding stroma, but they do not infiltrate it. They resemble perfectly smooth marbles embedded in the breast tissue.
Pushing, not permeating.
Exactly. Conversely, invasive SPC is identified by the breakdown of those smooth contours. The advancing edge of the tumor becomes ragged, irregular, and complex.
The WHO vividly describes this as a geographical jigsaw pattern, right?
Yes. The cohesive nodules break apart into angular nests and cords that actively permeate through the desmoplastic stroma and adipose tissue.
Furthermore, invasive SPC frequently demonstrates a really specific pattern of progression. It turns into mucinous carcinoma.
Yes, driven by aberrant MUC2 expression. The neoplastic cells begin secreting massive volumes of extracellular mucin.
So the invasive component morphologically transforms into these small clusters of tumor cells suspended within large lakes of mucin, just infiltrating the breast parenchyma.
It's very visually striking, yet much like EPC, the pure in situ form of SPC with smooth contours is exceptionally indolent. The survival data completely justify staging pure SPC as PTT.
I mean, the prognosis data is incredible.
It really is. There's a landmark cohort study cited in the guidelines that demonstrated that out of 76 rigorously defined cases of SPC lacking frank invasion, there were 0 instances of axillary lymph node metastasis.
0 out of 76.
0. This specific data point dramatically alters surgical management. Patients diagnosed preoperatively with pure SPC should generally be spared the morbidity of a routine sentinel lymph node biopsy because the risk of metastasis literally approaches 0.
It highlights how precise morphological subtyping directly prevents surgical overtreatment. But getting that preoperative diagnosis accurately brings us to the complex intersection of mechanical artifact and microscopic interpretation.
The needle and the damage done.
Sometimes the confusion isn't caused by the tumor at all, but by our own diagnostic tools. Let's talk about procedural artifacts. When we perform a core needle biopsy, we are firing a spring-loaded large-bore needle through dense fibrous breast tissue directly into a highly vascular, friable tumor.
The mechanical forces involved are immense.
And those forces frequently cause a phenomenon known as iatrogenic displacement. The biopsy needle physically shears clusters of epithelial cells off the delicate papillary fronds and forcibly drags them along the biopsy tract.
It just rips them right off.
Yeah, and these displaced clusters are deposited deep into the adjacent normal stroma, the surrounding adipose tissue, or they're even mechanically forced into nearby lymphatic or vascular spaces by the pressure wave of the biopsy device.
And when the definitive surgical excision is subsequently evaluated under the microscope, the pathologist observes these isolated clusters of neoplastic epithelial cells sitting naked in the stroma, far removed from the primary tumor mass.
And morphologically, a cluster of epithelial cells located deep in the stroma mimics true biological invasion perfectly.
It looks exactly like invasion, and here's where junior pathologists frequently fall into a catastrophic trap. They attempt to resolve the issue using immunohistochemistry.
Like we just said not to do.
Exactly. They reason that, okay, if these stromal clusters are biologically invasive, they will lack myoepithelial cells. So they apply a P40 stain, see that the clusters are negative for MECs, and they confidently diagnose invasive carcinoma.
Which is a fundamental misunderstanding of the artifact.
Yeah.
You absolutely cannot use myoepithelial stains to evaluate displaced epithelium. It's of zero value here.
Zero. When the needle violently rips the epithelial cluster from the frond, the delicate myoepithelial layer is left behind, attached to the basement membrane. The displaced epithelial cells are essentially stripped of their MEC layer by the mechanical trauma.
Therefore, a displaced cluster will always lack myoepithelial cells.
Always. The negative P40 stain merely confirms the physical absence of the cells, but it offers zero information on whether that absence is due to biological invasion or mechanical avulsion.
Relying on the absent MEC layer here literally guarantees a false positive diagnosis of invasion. So how do we tell the difference? How do we spot the artifact?
To differentiate mechanical displacement from true invasion, the pathologist really must act as a forensic investigator. You have to examine the surrounding stroma for evidence of trauma.
So we look for clues. Is the distribution of these epithelial clusters linear, perfectly mapping the path of a biopsy needle?
Right. We look for the biological debris of the trauma. The needle severs capillaries, leading to localized hemorrhage. Over the subsequent weeks before the surgery, macrophages engulf the erythrocytes and metabolize the hemoglobin into hemosiderin pigment.
So we look for linear tracks of hemosiderin-laden macrophages.
Exactly. We look for multinucleated giant cells orchestrating a foreign body reaction against disrupted keratin or necrotic debris. We look for early granulation tissue and localized fat necrosis.
In contrast, true biological invasion does not follow a linear trauma tract. True invasion demonstrates an organized, infiltrative growth pattern, radiating outward, inciting a diffuse desmoplastic stromal reaction characterized by activated myofibroblasts, rather than a localized hemorrhagic repair response.
Crucially, the diagnostic integration requires the clinical history. The pathologist absolutely must know that a core biopsy was recently performed at that specific site. If you don't look at the clinical history, you'll miss the context entirely.
And the warning here gets even more intense, because the mechanical transport of these cells can extend far beyond the local biopsy tract. The WHO guidelines provide a stark warning regarding mechanical displacement into the axillary lymph nodes.
Yes, the displaced cells forced into the lymphatic vessels can travel all the way to the sentinel nodes.
And furthermore, the standard pre-surgical protocol for a sentinel node biopsy involves injecting a radiocolloid tracer into the breast and vigorously massaging the tissue to promote lymphatic drainage.
That physical massage acts as a pump, physically forcing iatrogenically dislodged tumor cells deep into the subcapsular and medullary sinuses of the sentinel lymph node.
So when the pathologist examines the node, they find clusters of cytologically bland epithelial cells. And if they apply standard staging criteria, they would classify this as PN1, micrometastasis, or isolated tumor cells.
Which would fundamentally alter the patient's adjuvant therapy regimen, potentially triggering entirely unnecessary systemic chemotherapy.
To avoid this upstaging error, the pathologist must correlate the nodal findings with the primary tumor morphology. If the primary tumor is a papillary lesion that recently underwent biopsy, and the nodal cells lack the cytological features of high-grade malignancy,
they appear completely bland.
Right. And particularly if they are associated with a localized histiocytic or giant cell reaction within the node, which indicates a response to mechanical trauma rather than biological engraftment, the pathologist must report these as mechanically displaced cells, not true metastatic disease.
If the staging remains PN0, do not upstage based on a needle track.
Okay, while we're on the subject of needles, The mechanical limitations of our diagnostic modalities also heavily impact fine needle aspiration cytology, or FNA.
Yes, cytology has major limitations here.
While core biopsies provide architectural context, FNA yields only a cellular aspirate. And the FRCPath guidelines are exceptionally clear regarding the limitations of cytology in evaluating papillary lesions.
The primary issue is intralesional heterogeneity. A complex intraductal papilloma might be 2 centimeters in diameter. A 3 millimeter focus of high-grade DCIS can easily be hiding deep within its complex arborizations.
Right, and the fine needle only samples a microscopic fraction of the total tumor volume. If the needle successfully aspirates the benign hyperplastic components and just misses the focal DCIS, the resulting cytology smear will appear entirely benign.
It's a massive sampling error risk. Due to this inherent sampling error, the FRCPath guidelines mandate that the absolute minimum C category a pathologist can assign to A and Y papillary lesion evaluated by cytology is C3, which denotes an atypical, probably benign lesion.
So assigning a C2 category, a definitive benign diagnosis, is just never appropriate.
It is considered diagnostically unsafe because the cytological smear can never guarantee the absence of a localized malignant clone within the unsampled architecture. A C3 diagnosis forces the clinical team to proceed to a core biopsy or a diagnostic excision to properly evaluate the architecture.
However, there is one highly specific cytological signature within the papillary spectrum that is strongly diagnostic, right?
Yeah.
The profile of solid papillary carcinoma.
Yes. SPC has a very unique cytology signature. While standard papillomas yield aspirates containing complex, branching three-dimensional tissue fragments, the aspirate of an SPC is profoundly different due to its distinct biology.
Because SPC is characterized by a loss of cellular cohesion, often related to the downregulation of E-cadherin or P120 catenin complexes.
Consequently, the FNA smear is typically very hypercellular, but the cells are dispersed. You observe highly discohesive, loosely aggregated clusters and numerous single cells.
And cytologically, the cells exhibit granular eosinophilic cytoplasm and eccentric nuclei, manifesting this sort of plasmacytoid or neuroendocrine morphology.
But the truly definitive feature of an SPC aspirate is actually a negative finding.
Oh, the background cells.
Yes. In a benign papilloma, the mechanical trauma of aspiration strips thousands of supportive myoepithelial cells from the fronds, depositing them right onto the glass slide. These appear as small, dark, naked bipolar nuclei scattered densely throughout the background of the smear.
But in solid papillary carcinoma,
Because the internal myoepithelial network is largely absent or highly attenuated, the cytological background is starkly clean. The characteristic naked bipolar MEC nuclei are completely missing.
so the combination of hypercellular discohesive clusters, eccentric plasmacytoid nuclei, and crucially, an absence of background myoepithelial cells constitutes a highly specific cytological signature for SPC.
It allows the pathologist to raise a very strong suspicion of this specific entity prior to the core biopsy even happening.
All right, as we transition to integrating all these morphological and mechanical nuances into our final reporting, let's tie all of this clinical data together with molecular profiling and final reporting standards. Because while morphology drives the primary diagnosis, the molecular signatures, specifically the PAM50 intrinsic subtypes, really dictate the ultimate clinical behavior and targeted therapies.
Yes, the practically relevant molecular pathology is becoming unavoidable. The PIM50 gene expression assay fundamentally splits our two problematic entities, EPC and SPC, validating their separation into distinct WHO diagnostic categories.
Let's break that down. Encapsulated papillary carcinoma almost exclusively demonstrates a luminal A molecular phenotype, right?
Correct. This profile is driven by strong estrogen receptor signaling, but is characterized by a very low expression of proliferation-related genes, such as Ki67.
And that luminal A phenotype precisely explains the indolent, slow-growing clinical behavior of EPC that justifies the PT's staging we talked about earlier.
Exactly. It molecularly validates the staging. Solid papillary carcinoma, however, frequently exhibits a luminal B phenotype.
So it's still estrogen-driven, but
The luminal B profile is characterized by a higher intrinsic proliferative capacity and an upregulation of cell cycle progression genes. This molecular distinction is clinically vital.
because if an SPC undergoes frank invasion, its luminal B biology indicates a higher risk of recurrence and a potentially more aggressive metastatic trajectory than an invasive EPC.
Exactly. The oncologist uses this data to weigh the necessity of adjuvant chemotherapy alongside standard endocrine blockade.
Furthermore, the WHO details specific actionable driver mutations within these tumors. Activating mutations in the PIK3CA gene, which drives the PI3KK-KT-mTOR signaling pathway, are identified in approximately 43% of both solid and encapsulated papillary carcinomas.
And identifying that mutation is no longer purely academic. In the context of an invasive ER-positive carcinoma, the presence of a PIK3CA mutation immediately qualifies the patient for targeted therapies utilizing PIK3CA inhibitors such as alpelisib.
By inhibiting the specific mutated kinase driving the cellular proliferation, we provide a highly effective, targeted therapeutic option for patients with advanced disease.
The guidelines also highlight the evolving utility of loss of heterozygosity, or LOH, mapping. The papillary lesions frequently exhibit LOH on chromosome 16, however, the exact locus is the discriminator.
Right. LOH data is so interesting here. The WHO notes that LOH, the 16p13 locus, is basically a generalized event occurring in both benign papillomas and malignant papillary carcinomas, offering no diagnostic utility whatsoever.
It's useless for differentiating them, but LOH at the 16q23 locus is a specific genomic hallmark of the low-grade neoplastic pathway.
Loss of this specific locus, which houses several putative tumor suppressor genes, is identified exclusively in atypical ductal hyperplasia, DCIS, and malignant papillary lesions.
So while we primarily rely on the ADH5 cocktail morphology today, the identification of 16q23 LOH via molecular sequencing offers a definitive, objective adjunct to confirm malignancy in morphologically equivocal cases. It's a very powerful tool.
So ultimately, all of this complex morphological, mechanical, and molecular data must be synthesized and translated into a standardized code that the surgical team can immediately action.
We have to give them a bottom line.
Right. And in the UK, this is the FRCPath B category system. The B categories are the final output of our diagnostic algorithm. So let's do a rapid-fire summary of the reporting categories to solidify the framework for the listeners. How do we apply these categories to papillary lesions on core biopsy?
Okay. B1 indicates normal tissue and is essentially irrelevant here unless the biopsy completely missed the lesion. B2 denotes a definitive benign abnormality. As we discussed with the limitations of cytology and core sampling, confidently assigning a B2 to a core biopsy of a papillary lesion requires the pathologist to see the entire intact lesion on the core, with perfectly retained myoepithelial stains and absolutely no cytological atypia.
Which in practice is exceedingly rare.
It's a unicorn. Therefore, B3 becomes the operational default category for the vast majority of papillary lesions on core biopsy. B3 signifies a lesion of uncertain malignant potential.
And a B3 diagnosis forces a multidisciplinary discussion.
Exactly. If the B3 is based on a morphologically benign papilloma lacking atypia, the team will typically proceed with a vacuum-assisted excision for definitive removal. If the B3 designation is triggered by the presence of focal atypia, such as ADH, it mandates a formal diagnostic surgical excision to evaluate the entire architecture.
What about the malignant categories?
The malignant categories are B5A for in situ disease, which encompasses papillary DCIS, and crucially, the unruptured, encapsulated, and solid papillary carcinomas, reinforcing their PT as clinical management. B5B is reserved for definitive invasive disease, EPC or SPC with frank invasion beyond their borders, or the rare, true, primary invasive papillary carcinoma.
But the most critical safeguard built into the FRCPath system is the B4 category, designated suspicious. A pathologist utilizes B4 when the morphology is highly concerning for a B5A in situ lesion. Perhaps they see a high-grade clonal proliferation, but the core biopsy is fragmented crust or the IHC stains are equivocal, preventing a definitive, legally binding malignant diagnosis.
And there is an absolute rule here, the B4 absolute rule. A surgeon must never, ever initiate definitive therapeutic oncological surgery, such as a mastectomy or axillary clearance based solely on a B4 report.
Never.
The B4 explicitly mandates a secondary diagnostic procedure, typically a wide local excision, to acquire more tissue and achieve a definitive B5 diagnosis. It is a critical failsafe that protects patients from catastrophic, irreversible surgical overtreatment based on incomplete histopathological data.
We have to have that safety net. All right, before we wrap up, we need the final clinical pearl, and this is a big one.
Yes, regarding the microenvironment surrounding these lesions, specifically EPC.
When a pathologist evaluates an excised EPC, their attention cannot remain solely on the encapsulated tumor. They must meticulously examine the adjacent uninvolved breast parenchyma. Why is that?
Because EPC frequently arises in association with standard conventional ductal carcinoma in situ spreading through the adjacent terminal duct lobular units.
The DCIS is just hanging out in the normal breast tissue next door.
Exactly. And the presence of this peripheral DCIS dramatically alters the biological risk profile. While the EPC itself is indolent and adequately treated by local excision, any residual DCIS left in the adjacent breast tissue significantly elevates the risk of local recurrence.
It spikes a recurrence risk. If the pathologist fails to identify and document the presence and extent of that surrounding DCIS, the surgeon will assume the localized excision of the EPC capsule is totally curative.
And the patient will suffer a recurrence driven entirely by the undetected peripheral disease. The presence of adjacent DCIS changes the surgical approach. It mandates a much wider surgical excision to ensure clear margins across the entire affected ductal network. It must be documented separately.
This emphasizes that our role extends far beyond merely naming the primary tumor. We are mapping the entire disease process to guide the surgical strike.
That is the essence of pathology.
We've traversed an immense amount of complex pathology today. We've established that morphology, the architectural assessment to the H&E slide, must always dictate the interpretation of our stains. We've detailed how P40 prevents the false positives caused by reactive myofibroblasts, and how the ADH5 multiplex cocktail reveals the clonal uniformity of a neoplastic proliferation.
We have analyzed the stringent nuclear grading criteria required to apply the 3mm rule and the critical exception that any high-grade clone overrides spatial measurements. Size matters unless grade dictates otherwise.
Exactly. We've navigated the staging paradoxes where biological outcome data justifies staging structurally invasive EPC and SPC as PTS, while remaining incredibly vigilant for the biological overrides driven by aggressive molecular phenotypes.
And we highlighted the forensic analysis required to distinguish iatrogenic needle displacement from true biological invasion, preventing devastating overstaging in the sentinel lymph nodes.
The integration of this morphological discipline with the emerging molecular data from PM50 phenotyping to PIK3CA mutations really represents the current zenith of diagnostic breast pathology.
It demands an exhaustive attention to detail, a deep understanding of cellular biology, and a very healthy skepticism of our own diagnostic tools. Clinical history is often the ultimate tiebreaker.
Absolutely. So, as you prepare for your FRCPath examinations or as you sit at the multi-headed microscope tomorrow morning, I want to leave you with a final, slightly provocative thought to chew on.
Oh, let's hear it.
We currently spend immense intellectual energy debating morphological boundaries. Whether a contour is ragged enough to constitute invasion, or whether a MEC layer is truly absent or merely attenuated. But we just discussed how a highly aggressive biological phenotype can completely override an intact morphological capsule in EPC. With molecular tools like PM50, mutational profiling, whole genome sequencing, and spatial transcriptomics becoming cheaper, faster, and more accessible, are we moving toward a future where the classic MEC algorithm and morphological borders become entirely obsolete? Will we eventually replace the H&E entirely, relying solely on the genetic code of the cells to dictate staging and treatment?
That is the ultimate question for the next generation of pathologists.
It is. But until that molecular horizon arrives and fully takes over, mastering these morphological paradoxes remains the absolute most powerful tool we have. Behind every B-category rule and micrometer measurement is a real patient waiting for an accurate answer. Thank you for joining us for this advanced deep dive. We will conclude here.